Amy Stanwood, and today we are going to be talking about how to evaluate bone loss. The reason why this is so important is because hip fractures or fractures in general increase as people age. As you can see here, this is essentially you build bone in your younger years, and then you just kind of turn over bone. And as you start to hit your, for women, 40s to 50s, the age of menopause, you start to see bone loss increase. And for men, it doesn't typically start until they're after about 65 or 70 years old. So this is a drastic increase in the fracture rate in men and women. And this is why it's really important that we are looking at our older patients for bone loss. So when do you screen? Well, the United States Task Force recommends screening for osteoporosis in any women age 65 years or older, or any men 70 years or older. And now you see why based on that chart. The other thing you want to do is you want to screen anybody who has a fragility or a low trauma fracture. And we'll talk about that in a second. And then anybody who's got an increased clinical risk for fracture. So those may be, like we mentioned, advancing age, someone who has had a previous fracture that may not have been traumatic, anybody on glucocorticoid therapy. And typically what we think is that when somebody's been on continuous glucocorticoids for 3 months or more, that's when they are at risk for bone loss. So you might see that in patients with rheumatoid arthritis or patients who have COPD or asthma or things like that. Parental history of a hip fracture is actually a pretty significant risk factor for fracture. So one of the questions I'll ask my patients is, if their mother or father fractured a hip, and you have to clarify because sometimes they will say, that they fractured a hip when it really was just a hip replacement for other reasons. So that's something to think about. Patients with low body weight. So our BMIs in the low 20s, under 20, would be somebody that you would want to screen because heavier people have better bones. Current cigarette smoking is also a risk factor. Excessive alcohol consumption, typically we think anything more than 3 drinks per day. Rheumatoid arthritis is a risk factor for fracture because it's an inflammatory disorder, and oftentimes those people are on chronic steroids. And then secondary osteoporosis, such as low testosterone, early menopause, malabsorption, such as celiac disease, chronic liver disease, or inflammatory bowel disease. So how do you screen bones? Well, we have a couple of instruments. The most common one that you would order in practice is a bone mineral density test. And this is essentially an x-ray where the patient goes in and they x-ray areas at clinically relevant fracture sites, such as your spine, your hip, and your forearm. And this is very predictive of fracture risk. And so what you can see here is this is essentially what a bone density test looks like. On the top picture here, you would get a report after you ordered it that listed out the scores, and we'll go through that. The other way that you can assess screen bone loss is through a FRAX risk assessment tool. This is something that was developed that's typically used in conjunction with the bone density test, but in somebody where you might not have a bone density test available, or for whatever reason they can't get one, and you still want to assess fracture risk, you can do it through this tool, and we'll talk about that more in depth. FRAX was essentially developed to estimate the 10-year probability of a hip fracture or a major osteoporotic fracture for untreated patients. Age 40 to 90 years old. So again, the key is we only use FRAX for untreated patients. So let's talk about this bone density. So a bone density, or a DEXA, we call it, will report to you a T-score, and likely it will also report a Z-score. The T-score is the number of standard deviations that's compared to bones of a healthy 30-year-old. So if you're getting a bone density test on a 70-year-old, they're looking at what a 30-year-old bone should be and determining how much loss there is compared to that. A Z-score is the number of standard deviations for the healthy same-aged person. It's concerning if it's below -2. Now, the way to differentiate these is we really only use Z-scores in anybody under the age of 50. So somebody may get a bone density test in a young person because they have HIV and they're at high risk for fracture, or they're on chronic steroids. You know, they're not getting it as just a screening tool when somebody's aging. They're getting it for other reasons. So if it's under 50, you don't interpret the T-score. If the patient's under 50, you interpret a Z-score. T-scores are for 50 and older. When you are looking at your results, one thing to remember is we classify bones as normal, osteopenia, which is now referred to as low bone density, and osteoporosis. There's also a level even higher called severe osteoporosis. The T-scores, so a T-score of -1 to -2.5, or I'm sorry, anything above a -1 is considered normal bone. And then, you know, as we progress forward and you can see the matrix of the bone gets worse, osteopenia is a -1 to a -2.5 standard deviations, and osteoporosis is less than -2.5 standard deviations. So you can see here my example. This is just the results section of a bone density test that I would get at work. So I cut half of it out, but basically what you can see is that they record the BMD, which is the bone mineral density in grams per centimeter squared. They're going to report a T-score as well as a Z-score. So if this patient was under 50, you would look at the Z-score. But if they're over 50, you're going to look at the T-score. And you can see here in the spine, the T-score of a -2.7 is consistent with osteoporosis right here. They're also going to report FEMUR. They usually don't. In some cases, they'll report right and left. In this case, they just reported left. -2.8 would be consistent with osteoporosis. And then as you can see on the total hip left, they reported as a -2.1, which is consistent with mild bone loss or osteopenia. Now, when you're looking at a bone density test, any level that's osteoporosis, you interpret the highest level. So if the spine is osteoporosis and the hip is osteopenia, this patient has osteoporosis. You always go with the worst one. Now, FRAX is only reported when it's mild or low bone density. I still call it osteopenia. They've changed the terms, but I can't get past the osteopenia. And I don't think a lot of the radiologists can either, because you'll see it on your reports. FRAX is a score that is added to a bone density to help assess fracture risk. And it's only when you have osteoporosis, you're going to treat this patient. Osteopenia is kind of another realm, and we'll talk about that. So for FRAX, it's not applicable because this person has osteoporosis. And a trabecular bone score we're going to talk about. I pulled this example from one that's coming up, so you'll see that in a second. So we talked about a bone density test telling us osteoporosis, but the other thing I want you to think about is any fragility fracture is technically osteoporosis. This is usually defined as a fall from a standing height or less. So for instance, you should not fracture when you are standing on the ground and fall over. Your bone should be strong enough to withstand that force. And if you have a patient that is, typically, like if they're falling over and they break a hip, that's considered a fragility fracture. Now, typically, you can think about this as a fracture that should not have occurred. The most common sites for a fragility fracture are your spine, your hip, and your wrist. Now, it can also occur at your humerus, your rib, your pelvis. But sometimes you'll have people come in, or you'll get a referral, at least I do in endocrinology, for somebody who hit their toe on the side of the chest of drawers in their bedroom, and they want to know if that's a fragility fracture. And we typically don't think that fractures at like the skull, the cervical spine, not the lumbar or thoracic, just the cervical, the hands, the fingers, not the wrist, but the fingers, the feet and the ankles are not typically considered fragility fractures. And I got to be honest, this is hard for me. We get a lot of osteoporosis consults, and sometimes really understanding if somebody's fracture should have happened can be hard. So for instance, I had a patient who was a Marine, and he was constantly wearing a backpack. And after he got out of the service, he just had this thing where he had to wear a backpack. It just made him feel comfortable. And so he wore a 20-pound backpack everywhere he went. He ended up getting fractures in his spine. And, you have to kind of decide, is that a fragility fracture? He wasn't that old. Is that trauma from wearing a backpack all the time? I mean, those are hard decisions sometimes. Remember, fragility fracture is a clinical diagnosis with or without a bone mineral density. In some cases, you will have a fragility fracture and you'll get a bone density test and it will be normal. And that's where you kind of have to override the bone density test and say, this is still a fracture that shouldn't have happened. I am going to make a clinical diagnosis of osteoporosis. Stress fractures are not fragility fractures. Stress fractures are from repeated events that cause the fracture, like running too much, etc. So something to think about. In many cases, you'll be referring these fragility fractures to endocrinology. We get so many referrals for osteoporosis and fragility fractures that I'm hopeful that after this talk, you guys will feel comfortable starting some of the process on your own in the primary care realm. So let's move on and talk about FRAX. FRAX is a fracture risk assessment tool. And basically what you do is if you Google FRAX, F-R-A-X, it's going to come up with this Sheffield, or it says Sheffield something when you Google it. And you're going to get this fracture risk assessment tool. Now, you may not have to fill this out. If you get a bone density test, the way the radiologist departments are working is they give patients this questionnaire, they fill it out, and then they calculate FRAX for you. Times when you would want to use FRAX is if you don't have a bone density, or if you want to, or if your radiology department doesn't add a FRAX assessment into your bone density. So basically you fill this out. It's age, sex, weight, height, previous fracture, parent fracture to hip. Now that's when you really want to clarify, because like I mentioned earlier, often people get hip replacements and you need to clarify with your patient if their parent actually fractured a hip or had a hip replacement, because this is heavily weighted towards treating. FRAX is a tool that we use when somebody is diagnosed with osteopenia and we need additional information to determine whether to treat. So in the old days, anybody with osteopenia got treated, because what we know is that when people fracture and they're older, they do not do well. Somebody once told me 30% of people die within the first year, 30% of people end up in a nursing home, and, the rest of them do fine, 35, 40% do fine. But the risk of morbidity within that, or mortality within that first year, is significantly high. So this tool is going to allow us to gain additional information to determine whether or not we're going to treat our patient. So again, back to this. So you're looking at parent fracture to hip. You're looking at whether or not they're a current smoker. If they're a past smoker, you don't check this. You're looking for glucocorticoid use. And what you're looking for is somebody who's been on steroids for over 3 months. And that's pretty much continuously. Rheumatoid arthritis, secondary osteoporosis, like we talked about, that would be like hypogonadism or celiac or something like that. If they drink more than 3 alcoholic beverages a day. And then if you have a bone mineral density, you put in the femoral neck BMD. And if you click on this button, which I can't because this is a screenshot, you can select T-score. You can choose what you want to put in here. And then you hit calculate. Now, what it's going to do is it's going to calculate a risk of a 10-year risk of whether or not you will have a osteoporotic fracture or a hip fracture or a major osteoporotic fracture. And we'll get into that in a minute. The nice thing about this tool is, it wants weight in kilograms and height in centimeters. So there's always a conversion thing over here from pounds and inches if needed. One of the things you might also see, and this is relatively new over the last 20 years. So a trabecular bone score, you're going to start seeing this being used more. I've just started seeing it in the last 1 to 2 years of my practice. But basically what a trabecular bone score is it's another way of looking at helping you make that decision of whether or not you think your patient has good bones or bad bones. So here's what I want you to think about it. The bone density test, a DEXA, that's going to tell us the quantity of bone. How much bone is there? And again, it's only looking at it kind of like a 2x4, right, on the outside. Whereas the trabecular bone score is really going to tell us the quality of bone. So if you look here, these two people in this picture, on the left are the spines, have identical bone mineral density tests, okay? But what happens is the architecture is very good in one of them and not so good in the other. So this is basically it takes the DEXA image of a lumbar spine and it creates this like grayscale pixel image of the vertebral trabecular microstructure. And so what'll happen is that's going to really influence your decision as to whether or not to treat. So this person up here looks like they have pretty good bones, and this person down here, my trabecular bone score is going to change my my FRAX score, and I will show you examples of that. So as of now, a trabecular bone score is not used to diagnose osteoporosis and is not typically used alone to initiate therapy. It's just kind of clinically useful to sort of monitor. Some people use it to monitor the effects of bisphosphonate and drugs like denosumab, which we'll talk about, or some of these anabolic agents that we have for bone. So by itself, a trabecular bone score less than 1.2 basically defines a degraded microarchitecture, where a trabecular bone score of 1.2 and 3.5 is partially degraded, and anything above 1.35 is considered normal. And I don't know why, but I can never remember those numbers. So let's actually look at a sample bone, a few of them. So these are excerpts that I have pulled from different bone density tests. This one was one that we had just seen. So you can see here, we're going to assume these people are all over 50 years old. Okay, so you've got this, and I don't know why they always come like this, where they are never lined up correctly. But anyway, this T-score in the spine is -2.7. In FEMNEC is -2.8, and then in hip is -2.1. So we said this is osteoporosis. We don't need a FRAX score. We already know we have bad bones and we're going to treat. This trabecular bone score, remember I said below 1.2, I'll just go back here, defines degraded, whereas, so this is significantly degraded microarchitecture. So everything here screams osteoporosis, and we need to treat those bones. Now, if you look at this impression below, this is just pulled from a completely different bone density test. So let's say you do a bone density test on a patient and it reports, hey, this is all normal bone density. There's no osteopenia, no osteoporosis. So FRAX is not applicable. They still did report trabecular bone score. And remember, less than 1.2 defines what we said, degraded microarchitecture. So this is somebody that even though their quantity of bone is good, their quality of bone is not good. Now, this is a tough situation because, do you treat this patient? Well, this is where we're going to talk about some other things that you assess, because sometimes this decision is very difficult. I have to say, deciding whether to treat patients, whether to continue treatment or stop treatment or give them a holiday can be really stressful. So anyway, let's look at this third one over here. What you can see is this one has a T-score of 2.1. So again, there's no negatives shoved in there. So that is normal bone in the spine. FEMNEC is a -1.8. So that's above our threshold. And that is essentially osteopenia. And then the T-score in the total hip is -0.4, and then the 1/3 radius. Now, sometimes what you will see in disorder called primary hyperparathyroidism, in many cases they will add the 1/3 radius, and the reason why is because for whatever reason, the type of bone in the radius is more susceptible to bone loss in this disorder. Now, sometimes you'll see the 1/3 radius added irregardless of what they have, but a good radiologist will catch, if the indication is listed as primary hyperparathyroidism, they'll throw that radius in there. And remember, any level of osteoporosis or osteopenia is that definition. So in this case, we have osteopenia. Now, they reported FRAX, okay? So what they said is that the chance of this person having a major osteoporotic fracture is 7.9% over the next 10 years. Chance of them having a hip fracture is 2.5%. Now, one of the things I did not tell you is that when you are looking at your FRAX, treatment is recommended if the chance of a major osteoporotic fracture is greater than 20%, or if a hip fracture over the next 10 years is greater than 3%. Within FRAX, each country has a different cutoff for what they recommend for treatment. And within our country, we recommend 20% for major osteoporotic and 3% for hip. Now, so based on this, I've got osteopenia, I don't have an elevated 10-year risk of fracture. So at this point, I'm thinking I'm not going to treat this patient. I'm just going to do the standard calcium and vitamin D. Well, they added a trabecular bone score. So what this is telling me, so basically what it says is the bone score is a negative 1.165. So what trabecular bone score does is it adjusts your FRAX. And they calculate this right in. And basically what they said is, okay, now your chance of a major osteoporotic fracture in this patient is 10.7. So it still doesn't meet our 20%. Look here. Elevated our FRAX score. So the bone microarchitecture is not good enough to say that these bones should not be treated. So now that I've got a hip fracture risk of 3%, this is going to change me to, yes, I'm going to treat this patient. So before we had these trabecular bone scores, I would not have treated this patient. Now that they're added in, it's giving me another level to make another level of information to make a better decision for my patient. So when you have bone loss, whether it's osteopenia or osteoporosis, you want to make sure you evaluate for secondary causes. Now, we know based on the graph I showed you earlier that fractures increase as people get older, but it can be abnormal for your bones to really deteriorate that way. And so you want to make sure that you know why they deteriorate. Sometimes you can't find a cause, but you want to make sure you've done your due diligence and gone through secondary causes. So if your patient has anorexia, obviously they're not getting enough calcium and vitamin D. If they've got celiac, or maybe you want to screen for celiac and getting, it's a simple blood test, looking at the celiac. Ours just says celiac test, but there's an antigen test that you can do, or I'm saying it wrong. I'm blanking it. But anyway, you want to make sure their vitamin D and calcium is adequate. So vitamin D is very controversial, but in bone loss, it should be above 30. In people who don't have bone loss, there's a lot of data that says we don't need to be putting a bunch of people on vitamin D, but in bone loss, we want it above 30. We want the calcium normal. Check a TSH, make sure they don't have a thyroid problem. Check a calcium, make sure they don't have a hyperparathyroid problem. Cushing's syndrome is essentially a syndrome where there is a tumor making steroids. So the side effects are these patients are gaining weight, usually rapidly. They have diabetes, they have high blood pressure, they have all the symptoms of having too much steroid. It's not terribly common, but it's something that you wouldn't want to miss. Other signs would be that the patient had easy bruising. So when you put somebody on steroids long term, they get easy bruising and really thin skin. So if you kind of see those features in a patient, you want to send them to endocrine or look up how to evaluate Cushing's. It's not that hard. Hypogonadism, low testosterone. The sex steroids are really important for bone in our spine. So really, if I have a lot of bone loss in the spine, I definitely am going to check a testosterone level. Hypercalciuria, anybody who's spilling a lot of calcium in their urine, and we evaluate that with a 24-hour urine calcium. There are some people who do just spill a lot of calcium in their urine, and it's an easy fix. You can try to put them on a low sodium diet. So I usually get a calcium and a sodium in my 24-hour urines, because if the sodium's high, that tells me it's pulling some of the calcium out. Low sodium diet, if that doesn't work, you can actually put them on like a hydrochlorothiazide and block that urine calcium so that you can put it back into the blood so it gets back into the bones. Rheumatoid arthritis, I don't typically honestly screen for that one. It's usually people, that's pretty obvious, but certainly that's something, just at least if you have osteoporosis, you can kind of go, well, maybe this is from their rheumatoid arthritis if they're already diagnosed. You might ask some questions about joint pain, things like that, but I don't usually just go ahead and get a bunch of rheumatoid arthritis tests. Alcoholism, like we talked about, 3 drinks a day. Kidney disease is, chronic kidney disease is very hard on the bones due to the PTH effect and phosphorus. Liver disease, I don't check for homocystinuria or hereditary hemochromatosis. HIV will cause bone loss, especially on a lot of the medications. Diabetes can. And then, in primary care, you're probably not going to be looking for these other ones. Just some things to think about. When you've exhausted your list and you're thinking, what the heck is this? You can make sure you haven't, the patient's not, the steroids, the anti-seizure medications, the immunosuppressants, et cetera, et cetera. And then a couple other contributors. So proton pump inhibitors, the reason why antacids cause bone loss is because in the calcium that we mostly see in a lot of our foods is calcium carbonate, and calcium carbonate requires an acid environment for calcium to be absorbed. So proton pump inhibitors decrease acid. And so when you have a drug that's continually decreasing acid in your body, your calcium isn't absorbed, and or absorbed as well. And the easy fix for that is switching them to a calcium citrate that doesn't require an acid environment. So this is the part that gets a little challenging. So now you're thinking, okay, I've got my patient and I need to determine, am I going to treat him? So osteoporosis, you are going to automatically skip the low and the moderate on this list. And you're going to go into I guess you could say moderate, you can. But if your patient is low risk for fracture, their T-score is greater than a -1, they have no hip or vertebral fracture, and their FRAX is less than 20 and 3%, like we talked about, then non-pharmacological treatment with just calcium and vitamin D, and then trying to eliminate what could be causing the bone loss. Are they a smoker? Can you get rid of steroids, etc.? Moderate risk for bone loss is a T-score greater than a -2.5 and no hip or vertebral fracture. And, the FRAX scores are still less than 20 and 3%. So this is somebody that you're kind of on the fence about. You're putting together data in your head and thinking, what is this patient in front of me going to walk away from me and fracture? And sometimes you can look at patients and just go, they just don't seem that frail. Maybe I'm going to monitor this a little bit longer. When you start getting into these high, very high, and very, very high, that should probably say, that's when we start to absolutely treat. And then what you're deciding is whether or not you're going to start with a bisphosphonate or an anabolic agent. And we'll talk about that a little bit. I think at the primary care level, if you've got somebody whose T-score is below a -3, you need to send them to endocrine at any site because they need to be on a big drug. If you've got somebody whose T-score is above a -2.5 and you are comfortable starting a bisphosphonate, pick, the one that I always go to is alendronate. I like the data. You can't know everything about every drug out there. You kind of have to pick the ones you're comfortable with. And alendronate is one of my go-tos. So I would use that and then refer for anybody who's got the elevated T-score, severe vertebral fractures, etc. So this is a good chart for you to just kind of look at and go, okay, what level of risk is my patient at? So, I kind of document in my notes, I'll say, okay, my patient has osteopenia, the etiology is this, and my level of risk is this, and I'm going to treat with this. And it's just kind of one of those things with every bone patient I go through my head of, what is the diagnosis? What is the cause? And how am I going to treat that? How do you choose therapy? This is literally in itself a whole nother talk. But basically, bisphosphonates are usually almost always first line, as long as the T-score is not below that -3. Now, I typically use alendronate. Risedronate can also be used. The reason why bones have become so hard is because there is data that says if you keep patients on these drugs too long, they are at risk of osteonecrosis of the jaw. They are at risk of, they are at risk of atypical femur fractures. So there's some thought that if you keep them on the drug too long, it affects their bone turnover and they can fracture. But I'm going to, again, go through some of that to show you what I think about that. But bisphosphonates are first line, reserved for primary care. Zoledronic acid is an IV form of a bisphosphonate. So that's great for anybody who you put them on alendronate. And if you don't remember this from pharmacology, you have to have them drink a full glass of water, not eat or take any medications, and sit upright for 30 minutes once a week. So usually the bisphosphonates we dose once a week. And it's kind of complicated to take. So if anybody's got reflux or they have pain when they take their bisphosphonate or they have Barrett's esophagus, we just go right ahead and give them zoledronic acid. It's an IV infusion that you will infuse once a year. And then anabolic agents. So our anabolic agents are abaloparatide and teriparatide. So one of the things I want you guys to think about is that we build bone up into our 20s. Okay. And then what happens? So bone is built by osteoblasts. I always remembered bone and blasts, building, blast, bone, whatever. Osteoclasts, I always remembered crashers, right? Bone crashers. So your osteoblasts are more active than your osteoclasts up until your 20s. That's how we grow. And then what happens is as your bones sort of stop growing, they start what we call remodeling. So your osteoblasts build, your osteoclasts break down. The reason why bone breakdown is important is because there's minerals stored in our bones. So, calcium, vitamin D gets released, and then the bone gets patched back up and built back up. And this process keeps going. Well, what happens when we have osteoporosis, like let's say you have a smoker, what happens with smoking is that the osteoclasts are more predominant than the osteoblasts. So you get more breakdown and you don't get that filling up of that bone adequately, and you keep getting breakdown and it just doesn't fill up the same because there's something inhibiting those blasts from doing their job. So when we think about our drugs, bisphosphonates, the job with bisphosphonates is to sort of rebalance that. So your blast and your class start, at the same level again. Anabolic agents really focus on the blast in terms of building bone. Okay, so that is a drug that we're going to use when somebody has severe osteoporosis. So that's why I'm saying to you, when the T-score is less than a -3, I want you to be sure to refer them, because we want to start them on anabolic agents before we start them on bisphosphonates. And our two choices right now for anabolics are abaloparatide and teriparatide, otherwise known as, I think, abaloparatide is Tymlos and teriparatide is Forteo. Rank ligand inhibitors, these are, I shouldn't say typically used in renal failure, because they're actually used. They're the only drugs we can use when like a bisphosphonate you can't use if your GFR is below 35. And so then you can use something like a denosumab, but we don't just typically use it. It's a very good drug that's used in osteoporosis, in many cases, but you want to think about it when you have kidney disease and can't put somebody on a bisphosphonate. The problem with denosumab is that there is a significant risk for rebound fracture after it's stopped. So these other drugs sit in the bone, and when the bone's recycled, they are recycled and activated. But denosumab is a drug that it doesn't sit in the bone like the other ones do. So when it is stopped, there is a significant risk for rebound fracture. So we really want to make sure that people don't miss these drugs. They're given once every 6 months, and they can take them for a very long time. The sclerostin inhibitors, this is a really new class. I'm going to be honest, I haven't even used them yet. I'm a little nervous because, we've got a drug called romosozumab. It's got great data. It does a really good job with bones, severe bone loss. But in one clinical trial, there was an increased risk of cardiovascular disease and MI, stroke, and essentially death from cardiovascular disease. So I work at the VA. My population is much older, so it makes me a little bit more nervous to use this medication. But that doesn't mean it's good. So let's talk about this osteonecrosis of the jaw just for a second. I think this slide just sums it up. When you see, I want you to take osteonecrosis seriously. So osteonecrosis is essentially where you have, your blood supply to your jaw is not there and you get necrosis. And so typically this is seen in people who are immunosuppressed or in patients who have active dental infections and they're not healing, things like that. So that, initially when bisphosphonates came out, there was a big concern about osteonecrosis and the dentist told people don't take them, blah, blah, blah. But it's really something that I don't want you to worry about too much. I would be cautious in people who are immunocompromised or in anybody who has active dental infection. So ask them, do you have any dental pain? Have you lost any teeth recently? Do you have any planned dental procedures? If they do, you want to hold your osteoporosis treatment for 3 months until they're all healed up from their procedure or whatever. Worst case scenario, just send them to dental for dental clearance so that you can use one of these drugs. But if you look here, years ago, they kind of put this into perspective that your risk of dying from a lightning strike is about 0.6%, and your risk of getting osteonecrosis of the jaw in somebody who has osteoporosis on these drugs is 0.1% higher than getting struck by lightning. Whereas your risk of a hip fracture or a fragility fracture is significantly high. So when you're looking at this charts, the benefits outweigh these risks in most cases, but definitely do the screening. So what about these atypical femur fractures? Well, what happened was when people were on bisphosphonates for a long period of time, and a lot of this was seen when we were putting on people on bisphosphonates for very mild bone loss. We were giving them to a lot of people because of this fracture. And what they found was that the risk of this atypical fracture, and it's basically like a compound fracture of the femur. If somebody comes to you and they're on a bisphosphonate and they have leg pain, you want to get an x-ray and make sure that you're not seeing this specific atypical femur fracture. What you can see is that it's really associated with the duration of use. And so in many of these cases, we will continue a bisphosphonate for 5 years, if not longer. What I want to tell you about your patients is that some osteoporosis is a chronic disease. This isn't something that you typically just always fix and it goes away. This is something people tend to have for life. And oftentimes you have to treat it long term. So, you want to kind of think about your fracture risk and decide whether or not you want to continue it. The risk is very low. It climbs significantly after, I would say, 7, 8 years. So something to consider. So now that you've learned all this and you're making your decisions and you've determined your treatment, now you have to say, all right, what next? Bones don't grow quickly. So how do I monitor compliance in this patient? We don't typically repeat a FRAX. It's not used to monitor treatment. It's really only used to help you with your diagnosis. You can get a bone density test every 2 years. In some cases, people get them earlier, but remember, bone changes take time. And so if you get them too close together, you're not going to see a big difference. And so it's really hard to monitor treatment. So you've got this person on this drug and you don't know whether it's doing anything. You don't even know if they're taking it right? So there's ways to look at this. a little bit earlier. So one of the things that we look at is something called bone turnover markers. These predict what we call rapid loss in bones. There's a urine test, a serum test, and a bone-specific alk phosphatase. So the one that is really recommended that you use in bisphosphonates is a serum CTX. And what this is basically you get a serum CTX before you start your patient on the bisphosphonate. And then what you do is a couple months after you start that bisphosphonate, you check a serum CTX and hopefully it drops by 50%. And I should have put that in the slides. But what you want to see is a significant reduction in your CTX. And that's going to tell you, number one, the drug's working. Number two, it's being absorbed. Number three, the patient's taking it. Any drug that is prescribed, with a full glass of water, having to wait 30 minutes can take a while. Or can be something that somebody potentially could miss. So we want to catch this early. So if I saw somebody on once a week alendronate and a few months later I did a serum CTX, and this has to be done first thing in the morning, fasting, and the serum CTX was still elevated, I may switch them to an IV dose of zoledronic acid just so that, because I have, I would go through the compliance issues. Are you taking it correctly? Are you missing it? Blah, blah, blah. And then if they were, I would potentially switch them because for whatever reason, they're not absorbing it. Bone-specific alk phosphatase is a marker that you can use. I find this tough. I've checked it for years, and I honestly sometimes don't know what to do with them. They are indicative of osteoblasts, and supposedly, over time, again, if your bone-specific alk phos is just climbing, it's predicting rapid loss. I find this a tough one to use. And then I mentioned the GI issues or compliance issues, change to zoledronic acid. So people always ask, when do I stop? When do I give a drug holiday? We used to say 3 years. You want to go back to that fracture risk. You want to look back and say, okay, is this patient at high risk for fracture? So if this very thin, frail woman is sitting in front of you who has a history of falls, that is somebody that's at high risk for fracture. That is somebody that I'm going to continue alendronate in. I may switch drugs. I mean, really, that's somebody you probably want to send to endocrine, but you can continue alendronate for up to 10 years in some of the newer data. You can continue zoledronic acid for up to 6 years. You can try, switching drug to see if you can get more bone loss, more bone protection. So, you don't want to just give these high risk patients a drug holiday. But if you've got somebody that's low risk and they've been on a bisphosphonate, their bone density test is improving, they don't have significant risk factors, you can take them off the bisphosphonate. And then what I would do is go back to that serum CTX level, and every 6 to 12 months, I would get a CTX. And if you start to see it climbing significantly, then you know that they are rapidly losing bone again, and you may want to stop that holiday and put them back on a treatment. So reevaluate your bone turnovers every 6 to 10 months. And then if you reevaluate a drug, or if you give them a drug holiday and then do a bone density test in 2 years, if they have more than 5% bone loss, then that is a reason to put them back on treatment. All right, so I know that was a lot, but hopefully you guys got something from that. And good luck treating your bone patients.